Hello everyone. Here we go again. This is our session number 2 on Hernia A to Z fundamentals, and today we are going to have this lecture on mesh and material selection for hernia surgery. Mesh and material is not a topic that is very fancy or people like to talk about, but for hernia surgery in adults, we almost always need a mesh to give to the patient a permanent repair, and there is different ways to do a repair and different meshes that can be used in a repair, and material is very important. This way material is very important to our surgery for hernia in adults, and is our responsibility as physicians, as surgeons, to decide which material is the best for our patients. Again, we are inside Hernia U, but this is an initiative sponsored by BDI, and we need to make this very clear. We are not discussing specifically any topic that is exclusive to BDI, but our examples of meshes during this lecture will be all BDI, but more important than the mesh itself, the brand of the mesh, is the concept that is behind, because the same concept can be applied for different brands of mesh. I'd like to begin with this slide. This is two videos, one 1967 and another 2017. They are the same car, but 15 years after, one for another. And both can ride you anywhere. You can drive either one coast to coast, and it will bring you from point A to point B. It's not an issue if you can, but which one is more comfortable, which one is safer. So that's the same in meshes. We know that everything that in our world evolved for the last decades. Our phones are different, our clothes are different, our aviation is different. And why not mesh would be different? They evolve as well as everything else in life. That does not mean that the old versions are wrong and they can work, but the issue is which one are safer, which one are more comfortable for the patient and for the surgeon. Those are the questions that we need to answer and understand when we discuss the evolution of meshes and material for abdominal surgery. The material evolved, but the surgery evolved as well. Those are pictures for 500 years ago, and those are, as far as I remember, the first drawings of hernia surgery that we have. It was in an atlas, and we see here the surgeon explained to the resident, and I'm pretty sure this is the resident because he has the finger pointed to the training person, and you have some sutures, some scissors, grasper, a knife, magic powder, all the material that he needed to do the hernia surgery. And actually the surgery was done like this, so no anesthesias. You need more anesthesiologists than surgeons because you need to hold the patient down. And you see the surgeon is not dumb. He put the patient head down, probably to have less bleeding, and he need to do the surgery very quickly, because just holding down the patient is not a kind of discomfortable situation. And the results, if the patient were lucky enough to survive, and we can see the surgeon pretty excited about the results. Unilateral hernia repair, bilateral. I don't know if the patient were happy, because as you can note, by that time the surgery of inguinal hernia need to include orchiectomy. So I don't know how much those patients are happy with the results, but that was the way. And thanks God that evolved. Now we have good technique. We don't need to do orchiectomies anymore, but the mesh evolved as well. But we know that in our market, FDA has more than 200 products approved for hernia repair. And it's difficult to figure out which one is the best or which ones are the best for our patient. But we need to understand each of them and pick up the ones that we think that are the best option for our patient. For me, this is the most important slide of the whole lecture. We are going to discuss here this first box. We are going to discuss the chemistry, the product of the mesh and how it is knitted or how it's built. But that's all that we discuss when we talk about meshes. But perhaps what we don't know is what happened with the meshes after we implant them. And we can have the same mesh implanted in two different patients with totally different outcomes. We cannot really predict how each individual will respond to a foreign body that is the mesh. We know that in surgery. We can do the same surgical technique, the same skin closure by the same surgeon, and one patient will have a nice healed scar, another patient will have a bad scar. And we question ourselves, why? We use the same product, the same technique, why we have so different outcomes? And that is the tissue response. Each patient has different healing properties, and we cannot really predict how they will respond to a mesh, to a foreign body. And that's how we can have different outcomes when you use the same meshes in different patients. But by the end of the day, what really matters is the quality of life. The patient, they don't really care if they have mesh A, B, or C, if they have even recurrence or not. They just only care if they feel good or not. And that's where we should aim when we do a surgery for a patient with a hernia. The quality of life that the patient will have back after the surgery. And perhaps in that point, mesh can make difference. We're not discussing only recurrence, but foreign body sensation, chronic pain. There is a lot of different outcomes that we can measure in a patient. But the most important one, again, is patient quality of life. Meshes are not new. The first publication, formal publication, has 50 years from Usher, when he published the use of polypropylene. I think the steel meshes are older than polypropylene, but in our modern era, what we still use nowadays is polypropylene, and is not a new material. We've been using in meshes for the last 50 years, and it's a pretty good material. Is biocompatible, is resist to infection. I'm not discussing that we should or should not use it in an infected field, but the material itself resists to infection, and has now a low cost. Is old technology that has been there for 50 years, so the cost has gone very low. We have a lot of publication about polypropylene, and it's a pretty safe material to be used for a hernia repair. So we have no doubt that polypropylene is a safe material to be used. The issue here is how much material do we really need? If we tear down 10 by 10 mesh, we will end with almost 50 meters or 50 yards of polypropylene suture. That's a lot of suture to knit together to create a mesh. If we go for bigger size, like for example 30 by 20, that's a size that we can use in a ventral repair, we have almost 300 yards of polypropylene knitted together to create a single piece of mesh. That's a lot of polypropylene. So that's perhaps what we need to address right now and understand if we really need all that material in one single piece of mesh. One concept that we've been seeing for the past decade or a little bit more is to reduce the weight or the diameter of the mesh. We always say weight in English, but what we really mean is diameter. Diameter is the weight by a determined area of the material. It's not only how much the material weighs, but how much does it weigh in a certain area. This is diameter. There's two ways that we can lower the diameter so that we can use less material in a mesh. One will be use thinner filaments. We want to use filaments that are thinner than the traditional ones. So thinning the filament. And another way is put them more far away from each other. We make wider pores. So people call microporous mesh, so they have wider pore. They are more spaced in the same area. By doing this, we can use less material to build the same size of mesh. And here we have comparison between the traditional polypropylene, we call Marlex mesh, and example of lightweight mesh or with a lower diameter. We can see this is a filament and this is another filament. This one is thicker than that one. It's clear with this amplification. And the pores are wider. So you see the distance between the filaments here and the distance between the filaments here. With those two maneuvers, you can use the two or just one of them, and you end with less material, so less weight by area. So here we have over 150 grams per square meter, and here we have 60 grams per square meter. So that's what we mean when we say lightweight meshes. We don't have very clear definitions what will be a heavyweight or a lightweight mesh. We know that everything that is over 90 grams per square meter is a heavyweight mesh, the traditional mesh. It can go higher as 150 or 180 grams, but anything higher than 80 grams per square meter is heavyweight. Anything lower than 60 will be reduced weight. So when we say between 40 and 60 will be what we've been calling the medium weight mesh, and anything lower than 40 will be lightweight mesh, and that is a subcategory of lower than 30 that will be ultra lightweight, and we have different meshes that fit on those different groups. But again, less than 40 lightweight, less than 30 ultra lightweight, 40 to 6 medium weight, over 90 heavyweight. Between 60 and 90 is not clear how we should categorize it, but perhaps medium weight. But what we have right now, most of the trials that try to compare meshes say that between 40 and 60 will be our medium weight meshes. And this translates in histology, and those are pictures from the paper from Shin Orenstein and Yuri Novinsky, published more than 5 years ago, just showing that how does it translate after the patient reaction of the mesh, the difference between lightweight and heavyweight. So in the top picture you can see the filaments, and everything that is in blue is the fibrosis. Once we go to the lightweight, this is the bottom one, you see that the filaments are a lot thinner than the heavyweight. So you have thinner filaments, and they are more spread out, so wider pore. You see the distance between those filaments and the distance between those filaments here in the heavyweight. And the middle picture is somewhere between those two that have the middleweight polypropylene, but it's clear how you have less fibrosis in lightweight mesh than when we compare with heavyweight mesh. And then in middleweight mesh you have more than lightweight but less than heavyweight. So what really matters is the reaction of the body to the mesh. So if you put less foreign body, we'll have less reaction, and perhaps it will be more comfortable for the patient. But the question raised is, okay, we are using less material to build the mesh, and the mesh will be weaker. We have less strength in the mesh, and that's true. Once we use less material, we have a mesh that have less strength, less material, less strength. And that was compared by William Cobb, more than 10 years ago. What is the force needed to tear down a mesh, to rupture a mesh, the burst load? If we have a heavyweight, this is 100,000 newtons that you need to tear apart a mesh, traditional mesh. If you reduce the diameter, you go to the lightweight mesh, you need half of the force to tear tear apart the mesh. That mesh is weaker than this one. Absolutely, no doubt about it. So people may fear, so wow, we are using weaker mesh, perhaps it's not a good idea. But the point that we need to understand is the fascia. We are fixating the mesh into the muscle, into the fascia. If we apply, or if it happens, a force higher than 300 newtons, the fascia will tear apart. So the mesh will hold, but it will be tear apart from the muscle, from the fascia. So there's no point to create a very strong mesh that will be fixated in a weaker tissue. So that's the point that we need to understand, that we really don't need that very strong mesh in the majority of the case, because the fascia is a lot weaker than that. We need something that is stronger than the fascia, and lightweight mesh is stronger than the fascia, but we don't need that, all that strength. And all this is regarding non-bridging repair. When we are bridging, we don't have the fascia to support, and it's another discussion. But when we do have closed defects and we do a reinforcement with the mesh, it looks like we don't need heavyweight mesh. Lightweight is weaker, but it is strong enough. This is another study from Hanford. He published more than 10 years ago as well, showing us the pressures that we have in our abdominal wall. And those are numbers that Usher 50 years ago, he didn't know how much pressure we need to play against an abdominal wall. Now we do know, and that paper was written and presented using the measurement by the bladder in humans, and asking the patients or the subject to do different exercise and measure the intra-abdominal pressure, again through a Foley in the bladder. And we noticed that perhaps coughing and jumping are the highest pressure that we can apply in our abdominal wall, and it will be less than 115 millimeters of mercury. When we compare that pressure to the pressures needed to rupture the mesh, we can see again the heavyweight is very strong. Over 1500 millimeters of mercury is needed to rupture a mesh, a heavyweight mesh. When we use a lightweight, that goes down less than half. Around 600 to 700 millimeters of mercury are needed to tear apart a mesh. But we never go that high. We humans, we cannot create that higher pressure in our abdominal wall. So again, that proves that if we don't breach and we have mesh as reinforcement, we are pretty safe using reduced weight mesh. And that's the point of this publication. But why we want to reduce the grammature? Let's play safe. Let's use heavy weight. I don't know, Flavio. Just let's be very safe. It's not free lunch. When we put more material, have more reaction, we can have more contraction of the mesh. And infection is another issue. Contamination of the mesh. If you have wider pores, we allow space for the macrophage and our defense cells to go inside the mesh and fight against bacteria. If you have smaller pores, micro porous mesh, perhaps the bacteria can hide within the filaments, and those big macrophages, they cannot go inside and clear the infection or the contamination. That's why when we use synthetic mesh in contaminated fields, we should target macroporous mesh that allows us to fight against any contamination, any bacteria that try to hide into the foreign body. And this is a very important point. Once I told you that we can reduce the grammature in two ways, creating wider pores or using thinner filaments. The use of thinner filaments does not guarantee macroporal mesh. So if you have to choose one of the two ways to reduce the grammature, we need to choose wider pores. So that way we are going to create macroporous meshes. Thinner filaments can help as well, but the most important aspect regarding the resistance or the ability to fight infection or contamination in a synthetic mesh is to have wide pores. Now that we understand the kind of material and the way that we needed the material to create a mesh, I'm going to go over different types of meshes. Then the first one is this 3-dimensional or anatomic mesh. One example for open surgery is the Perfix plug. We are going to discuss the technique in the next session, section number 3. Here I just want to show you the mesh is a 3-dimensional mesh, 2 parts. We have the plug and the patch. So those are the plugs and this is the patch. We have lightweight and heavyweight. It's a very quick and simple operation to perform. You can criticize it in different ways. My point here is not to discuss the technique, just to show you how the shape of the mesh can help us during a surgery. You can make the surgery quicker and perhaps less painful for the patient. In laparoscopy repair, we also have those three-dimensional meshes. And the example that we have is a 3D Max. It's like this shaped mesh. Our inguinal region, and more precisely our posterior inguinal region, is not flat. You have a shape, and that mesh tries to mimic the shape, so it lays more appropriately on that region. We have different size, and we have heavyweight and lightweight as well. That medium size, in my personal opinion, should not be used unless you are operate a real small patient, but I mean real small patient, a real short woman, and perhaps you can use a medium. Most of the patients, the majority of the patients, should be operate using a large or an extra large. Right now in my practice, I'm moving more towards the extra large, but I can see some patients that we still use a large. This is 10 by 15. Size is very important in laparoscopy inguinal repair, so we should not do less or smaller meshes than 15 by 10, and I rather go to 17 by 12 now in most of my cases. And it's just the shape of the mesh. It's just to help you to position the mesh, just make your life easier, and you can put the mesh that is not flat in a non-flat area. So that's how a 3-dimensional mesh helps you in your laparoscopy repair. Another group of the mesh are the coated mesh, and the last group that I want to address with you will be the bioabsorbable mesh. But talking about the coated mesh are the mesh that have some barrier to avoid adhesions. And usually those mesh are used to interperitoneal position. It's what we call the IPOM meshes. They have two different sides. One side that go against the wall, the parietal side, that side we want to integrate into the wall, and a visceral side. That side will be in contact with the viscera, and that side we don't want to integrate to the bowel or to the viscera. We want to create a barrier that will avoid adhesions. The majority of those barriers are absorbable barriers. They will stay for 1, 2, 3, or 4 weeks, and then they will be gone. And the question is the mesh is going to be forever into the cavity, and now you are putting a barrier for the viscera that only lasts for a couple of weeks. And how that works? And the answer is here. The peritoneal heals in a different situation than the skin, for example. We have island of mesothelium that grow in different areas of the mesh. So it's not a healing from the periphery to the bottom, to the center, for the periphery to the center, but small island that grows within the area of the mesh. In that way, that can be very fast. And we know that when we reoperate patients after 2 or 3 days, we see a thin mesothelium sometimes covering the surgical area. So that's how mesothelium heals, in islands, not really from the periphery to the center. We know that around 7 to 10 days, we have pretty much coverage of huge areas inside the abdominal cavity. So we call this critical period of time. Another concept that we need to go over is adhesion formation. We know to create adhesion, we need some risk factor. That can be trauma, infection, ischemia. In our case of mesh, it's a foreign body. We have a foreign body that creates some inflammation, some wound healing. That inflammation creates a fibrin exudate that will cover the foreign body, and that fibrin exudate can build bridges between two structures, the mesh and the viscera in our example. So, but all that process occurs in the first week or the first 2 weeks. So that adhesion that we operate on 10 years after a surgery has been there since the first week. And that's the point. If we stop that process on the first week, we probably will avoid adhesions. And so that's the idea, to have a temporary barrier. We don't need a barrier forever. We just need it in these first critical weeks to block this process of creating a fibrin exudate and fibrin bridge between the structures. And technically, when we avoid this for the first weeks, we give enough time to mesothelium, to the peritoneal heal. So after that period, the own natural peritoneal will cover the mesh. So that's the idea behind the IPOM mesh, or the coated mesh. The example that we have is SepraMesh. SepraMesh is polypropylene with a barrier that is Seprafilm. So we have this bioabsorbable layer and the polypropylene mesh. And the polypropylene mesh is the parietal side, parietal face. That's the one that go against the wall and will integrate into the wall. And the Seprafilm is the bioabsorbable face, or the visceral face, that will avoid adhesion between the viscera and the polypropylene. One good issue, or one good quality of that mesh, that it can be trimmed. There's some meshes that should not be trimmed, and sometimes you need to trim the mesh to get the best shape of it during a repair, and that mesh can be trimmed. And this purple color comes from Vicryl sutures that they are used to tie to fix it, the Seprafilm into the polypropylene mesh. It is reabsorbed in up to 30 days, so give us enough time to that mesothelium healing happen and protect the mesh, avoiding this fibrin bridge from fibrin exudate that we have with the foreign body, that is the mesh, that would create adhesion. We just try to block that progress while we give time to the mesothelium to grow and cover the mesh. And one point that is very interesting, that in this case, this is an expandable barrier. It swallows a little bit. And in that way, it can cover even checkers. Because we've seen before that sometimes we don't have adhesions to the mesh, but we have adhesions to the checkers. They're exposed into the visceral side. With this kind of barrier, it swells a little bit, so it may even cover sutures or checkers, and this is an extra feature of it. We have the same mesh in a lighter version, what we call lightweight, as I explained at the beginning. In that case, is Ventralight. It's the same technology, the Seprafilm, and the same polypropylene mesh in a lighter form. It's a lightweight IPOM mesh. Actually, this Ventralight is not lightweight, it's medium weight, but it is reduced grammature for us. It can be trimmed as well. This is how we can use it. We can use transfacial suture for fixation, or just one suture to centering position the mesh. We should wet the mesh before putting into the cavity, not long before, just before introducing through the trocar, and we do the technique, the proper technique that we are going to have lectures on the proper technique of laparoscopic ventral repair further in the course. Again, we have two sides, parietal and visceral, but that specific mesh, we can add some position system to help in position the mesh. And that's what we call echo PS, echo positional system. That is this kind of skeleton, the green skeleton, that opens up the mesh. And it is on the visceral side. So during a laparoscopic repair, you can see this. And that side will be the parietal side. That's the one that will go in contact with the wall, sorry. And this is a quick video, just a quick wetting of the mesh. That is a rolling device to make it really thin to go into the trocar. You have some specific way to do it. And just to deploy the mesh inside the cavity, you can open up, and you should retrieve this inflating tube. This example is a Swiss cheese defect. They are not going to be closed. And once you insufflate through that tube, the mesh opens and really help you to position the mesh, because it keeps it open against the wall. So it's really easy to position the mesh and to do the fixation. You should fix at least the peripheral crown, and then you let the air goes out and retrieve. You need to take out all this position system, and then you can finalize with extra external tackers or even a double crown technique. So that's the way that position sit helps. Every surgeon says that, oh, I don't need this, I can do the ventral technique laparoscopically without any difficulty, but this really helps. Once you get used to it, it's hard to go back, but it's just an extra feature that helps us during laparoscopy repair. Another type of IPOM mesh that is not for laparoscopy surgery, but for open surgery is Ventralight, and we are going to see how it works. It is designed to umbilical repairs or small umbilical hernias. You just resect the sac, reduce the contents, make sure there is no adhesions around the hernia defect. You position that mesh. This is a round mesh that has a ring that keeps the mesh open. So in that way, you just push it into the hernia defect, it will open, you retrieve those strips to keep mesh up against the wall, and you fixate those strips. So when you fixate those strips, you are fixating the mesh, and the mesh will be open because it has this ring, this absorbable ring, will keep the mesh open. With that, you don't need to create any subcutaneous flap to do only repair. You don't need to create any retomuscular space or preperitoneal space, and just the mesh just lays open against the wall. My personal preference, I like to do this technique in a preperitoneal space. I try to avoid an intraperitoneal mesh using the same mesh, but creating a preperitoneal pocket to deploy that mesh. It's just a different way of using the same mesh. You can use it as a prophylactic mesh, just by curiosity, just to show you that you can put it in 12 mm or 15 mm trocar's defects to avoid a hernia in a high-risk patient. For example, in bariatric patients, they can be used to avoid incisional hernias in bigger trocars. The other mesh that we need to talk about is Ventral. Ventral is the same concept of Ventralight. Ventralights are that size with the strips, and Ventral has a full family of bigger size. Those are for open IPOM surgery. The mesh have separate barrier protecting against the viscera, but have rings to keep open the mesh. Those rings are from PDO, and they absorb around 25 to 30 weeks, so they keep the mesh in place, but at a long range they will disappear. So the patient should not feel any discomfort with those rings. And they have those pockets, and here for me is the beauty of this mesh. Those pockets allows you to go inside and do fixation, and to keep the mesh really open and to avoid any viscera to get between the mesh and the wall. Then that's the way that we do. We just do open access, we dissect the hernia sac, we don't need to create any subcutaneous flap as for onlay repair, we don't need to create any retrorectal space as for Risby repair, or any preperitoneal space to do a preperitoneal ventral repair. We just open the sac, reduce the content, and make sure there is no adhesions into the wall. And through the defect, we put the mesh, and we need to be assured that the mesh is open, and we can do this through those pockets. You can put retractors, or you can put your fingers, and you'll be very comfortable assuring that the mesh is wide open. We don't want wrinkled mesh, we need open mesh. Once you have an open mesh, you are going to use those pockets to introduce tackers and fixate the mesh against the wall. One very important step is to keep medial traction to make the mesh really tight, open in this interperitoneal space. You do it one side, you do another side, you can use additional sutures to fix if you wish, but you do a full crown technique around the mesh inside the pocket, so you are not taking risk of injury any viscera. You are always inside the pocket. In that way you can do a very quick repair with IPOM mesh with no flaps. So those separate mesh, Ventralight, Ventralex, and Ventral are all IPOM meshes. Another group, or the last group, the meshes that we are going to talk about are the Bioabsorbable mesh, and they all were born with this ideal concept that we could create reinforcement without residues. So why that? Because we know that meshes are important because they provide support, but more important, they provide wound fibrosis, tissue integration. So the definite repair is not the mesh itself. It is the fibrosis that mesh allows our patients to perform. So we have fibrosis in the site of the mesh, and that fibrosis, that's what gives you long-term result or avoid recurrence. So can we invent something that will protect on the first weeks or first month, and will give the fibrosis, but in the future will go away? So we give some basis for fibrosis, but in the long range we'll have no residues. And this is the kind of bioabsorbable mesh. We have two groups: the biologic, that was the first group, and the synthetics one. So the biologic mesh, what is the process here? We have some tissue, human or not human, can be porcine, can be bovine, can be sheep, can be submucosa, intestinal submucosa, can be skin, some tissue that the industry takes and submit to a process that takes out all the cells. All the cells are gone. All you have left is the extracellular matrix. And this is kind of a framework to the healing, to the fibrosis. That extracellular matrix made of proteins, basic collagen, is the base from the host, the patient healing. So we have fibrosis. But that initial extracellular matrix will go away with time. And that's the basic concept of the biologic mesh. The example that we have from BDI is chain matrix. This is porcine derm. You can see those spaces because all the cells were removed, showing that it has good strength when we compare with different meshes, but it has really strength, resistant to be tear apart. And once we apply a biologic mesh, that is the process that we expect. We have inflammation. This is the first phase of wound healing. Degradation of the mesh, simultaneously with the collagen deposition from the host that is creating the fibrosis, and a final maturation phase that can take months up to years. So we just give the framework to the body, to the host, to the patient, so their own cells and fibroblasts can heal over that framework. And after a certain time, that framework goes away. This is preclinical data showing a lot of histologic maturation of fibroblasts into the mesh. So the mesh is really being integrated to the wall. And this one shows that is strength over time. The mesh will lose strength because the mesh will be degraded, but by that time, 8 weeks, 12 weeks, month after implantation, what we expect as the natural tissue of the patient to be growing over that framework. An option besides biologic bioabsorbable mesh are synthetic bioabsorbable mesh. The same concept of biologics, but origin is not tissue, is some material that is needed as a polypropylene, but it's not synthetic permanent, it's synthetic bioabsorbable. The example from the company is Phasix. Phasix is made of P4HB. It is break down in water and CO2, but it lasts 1.5 years to be degraded. And what we expect during this 1.5 years is the host to create fibrosis in that place. So once the mesh is gone, it's not problem. We will not have any weakness. One thing that is very interesting about phases is the absorption of the P4HB. It is mainly by hydrolysis, so we don't have a lot of inflammation going to degrade the material, but hydrolysis. And is fully absorbed in up to 18 months. And so again, the mesh starts to losing strength with the weeks, but by the time that the mesh loses strength, we have natural healing from the host, from the patient, increasing the strength. So what we expect after a year is the mesh is almost gone, but the strength is high because we allowed fibrosis to develop in that area. So, and we can evolve a little bit more, would be to do the same bioabsorbable mesh with a barrier for intraperitoneal use. Is the same idea of all other mesh with the separate barrier, but now with a bioabsorbable mesh. But the same concept of the separate visceral side and now in a bioabsorbable concept. Well, it has been long, but I need to talk about a fixation because we discussed a lot of meshes, but we need to fixate those meshes and somehow in our patient. We can have the tackers device that will shoot tackers and or prongs into the patient and to fixate the mesh. Those can be permanent or absorbable ones. We have different competitors in the market, different shapes, different penetration system, different length, but all of them works to try to fixate the mesh. The example of permanent suture that we have with the company is CapSure. Is very interesting because it's not only the metal, the stainless steel, but you have this cap, and that cap has the purpose to decrease adhesions. Once we do fixation in IPOM mesh, we're seeing that we can have adhesion to the tackers, and the idea here is to decrease the rate of adhesion. It's a very comfortable tacker. The grip and the fire is very smooth, and we have in 15 or 30, it depends if you're doing an inguinal or a ventral, you have to choose, but it's a very smooth firing process and a really strong fixation up to bone. I don't think that we should use in bone, but it can even penetrate a little bit in bone. And this is the way that it goes inside. And as I said before, the idea over this cap is to minimize adhesions. The absorbable tackers that we have, for example, here is OptiFix, is mainly the same idea of fixation with tackers. The trigger is different, is a spring load, so you don't control the fire. Once you do the trigger, and the instrument will hit and will fire a tacker. It's a different process of firing. And the prongs, they are not helicoidal anymore. They have these fixation tips that will hold it in place. And what I like a lot is the hollow core. So we have fibrosis from the outside and from inside. So theoretically, we have two fixation areas, outside and inside the prong. It lasts up to 1 year, but what matters for us is the retention strength. This is up to 4 months. After that, it loses the strength, but it will be gone only around after 1 year. Holds strength up to 4 months. That's what we need to have integration. It's more than we need to have integration of the mesh to the wall, but it will still be there up to 1 year. So, well, to wrap up what we discussed, this is a 1958 Cadillac, a very nice car, but nobody thinks of buying a 1958 Cadillac right now. I think our 2018 Cadillac XTS is a lot better than this one. This is a multimedia from 1958. Nobody wants that TV at home. The same with the phones, the same with computer. This is a 1958 IBM. I think in our iPhones we have a lot more technology that we used to have in 1958. The point is, the mesh they were launched in 1958 by Usher, and they evolved during the 5 decades, and we need to recognize it. There's nothing wrong on driving this car or using that phone, but everybody knows that we have more safe, more comfortable and safer ways to ride cars, watch TV, make phone calls, and we have safer and more comfortable ways to use meshes. And that, I think that's the point with that lecture. And the final and most important point is quality of life. We operate patients. We don't operate hernias. We should not care if the hernia recurs or not. We should care if the patient feels well or not a long range. Usually, if they have a recurrence, they will not feel well. But it's not only the recurrence. There's another factors that will run together to give good quality of life. Chronic pain is one example, and we'll have a full lecture on chronic pain later on the course. But we should try to use modern, evolved material to give quality of life. Let's not treat hernias. let's treat patients. I think that is my most important message. These are all information from the material that I shown here. We need to have those in the presentation, so if you want to revise all that information, you are free to do it and more than welcome to do it. I want to remind you to come to our Q&A session. So me, Eduardo, and Salvador will be live to answer all your doubts and questions. And you need as well to take the quiz. It's very important to take the quiz so you can have your certificate by the end of the course. Thank you so much for attention. I hope you have a nice time with this lecture. Bye.